This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. Hey, welcome back to the Alert Medic 1 podcast, everybody. Tonight, we're going to be doing something new called Medical Director's Corner. Don't know if it's going to become a regular thing or not, but we're giving it a shot tonight, and we'll see how it goes. So we've got myself, Ken, Moose, and the esteemed Dr. Launer on to talk about sudden ambulance death syndrome. Key is coined by the doc. So, want to take it away, Doc, on what we want to talk about?
What's up, everybody? So we'll wait for the ratings to come in to see whether it'll be a regular occurrence. But yeah, I did not coin that term. The term's been circulating around. We had some presentations on it in another neighboring jurisdiction. Then there were lots of, I think, hurt feelings about people doing the right thing and the wrong thing, and how does this gel with protocols? So I thought this would be a really good forum since we're today, for all disclaimer, we are in an evidence-free zone with respect to this. So I think it'd be a good place to talk about all the considerations and figure out how to translate the knowledge, because sudden ambulance death syndrome is kind of an umbrella term that was coined by a couple of medical directors. It's been utilized in Pittsburgh and in Texas. Dr. Bethany had mentioned it. And so I just wanted to talk about some of its implications for the care that we deliver every day and for the patient encounters that we see on a regular basis.
Let's do it.
How's that for the lead up?
You couldn't have done it better.
Well, I was listening to what Ken had to tell me. So I was struck by this because this all started. We all have, in my jurisdiction, which most of you can guess, we have the luxury of being very close to multiple hospitals. And in my experience, and the experience from the annals of our QA and QI and case studies, there are a lot of patients who are sick right outside the hospital. And I think it's been, a matter of cultural precedence and a matter of practice that if you're real close to a hospital capable of definitive care, then we should probably get patients to the hospital. And without question, transport is a treatment, right? We deliver patients rapidly. We've all heard the terms diesel bolus or rocket fuel, jet A for our helicopter, and there's absolutely no question there's a place for rapid transport. What I wanted to talk about today is really get into the weeds of when is it appropriate to take the pause and how do you take that pause? Because the problem, quite honestly, right, is, I'm still a paramedic, and I think when things get into protocol, we think all or nothing, right? So sometimes people say, well, then I got to stay on the scene all the time and treat versus I got to go because, we're in the shadow of definitive care. So I think to kind of set the stage, it's a good topic to kind of look at some of the protocols and some of the illnesses and how it kind of guides our treatment within the context of a variety of things that we like to encounter on a regular basis.
It's interesting you bring that up, and a conversation for another day, but maybe it's because me and you have had this conversation offline. I feel like it's too often now.
We probably should schedule a meeting about it, Moose.
Yeah, we should. I feel like so many of our conversations lately have been about clinicians thinking in extremes.
Yes.
And actually, we had a airway management discussion on Friday about this exactly, and it was interesting to see, the perspective of two different medical directors at that point. So, yeah, I'm excited to dive into this because certainly nuance is always at play.
Yeah, so let's just make it a little bit easier because you know me, I love to operate in black and white. The other medical directors are incorrect. So hopefully with that precedent, we'll talk about it. But no, I'm just kidding. I think you're exactly right. And part of this is how to get into a clinician's mindset. And without question, we are all clinicians at every level: EMT intermediate, advanced EMT, paramedic, specialty care paramedic. And I think that's the challenge, is you have to figure out how to apply these concepts to each individual encounter that you have. And I think that's a really good way to understand the sudden ambulance death syndrome. I think we'll talk about the description, we'll talk about some contextual points and how to kind of process that. But you're exactly right. It's getting into a clinician mindset, figure out what you think is wrong with the patient, And then basically the treatment decision has to be basically a kind of a synthesis about what you can do, what your capabilities are, and all of your environmental factors. Because you're absolutely right. The bottom line is we can't think in extremes. Sometimes multiple things can happen at once. But the issue of sudden ambulance death syndrome is very real in that sometimes there's no worse place to be than right around the corner. And I just want to lead off by saying that even right around the corner is very difficult. If you're right around the corner from the our intergalactic shock trauma center, for example, it's still going to be 5 to 6 minutes sometimes before you get up an elevator. If you are around the corner from a level 1, STEMI stroke receiving center, it's still going to take you a couple minutes to walk the patient. Oh, we never walk the patient, to get the patient from the scene to the ambulance, to load them up into the stretcher and then transport them. So the first thing I'd say is that being right around the corner of the hospital is still a significant period of time. And that is where these patients can certainly, who are at the extremes. Now, the patients are allowed to think in the extremes because we don't govern their physiology, but the patients are the ones that are at risk for deterioration.
So I think the two of you have brought up something really important, and that's this whole thinking in extremes thing, because this is something we see a lot, not only in EMS with clinicians, but in our society as a whole. Everything goes to the extremes now. Everything, like you said, black and white, right and wrong, left and right, however you want to phrase it, everything is an extreme. And I don't know if this is a generational thing or a cultural thing or where it comes from, but I don't feel like it used to be like that. Like even in EMS, I feel like if you go back 20 years, not everything was all or nothing. There was some middle ground there, but now it seems like we're in this point where everybody has to. It's all or nothing. You're all in or you're all out. Like it's either you throw them on the stretcher and you beat feet to the hospital, or you sit on scene for 30 minutes and do every protocol in the book. And that's not necessarily either of those are right in necessarily any given circumstance.
I think it's generational in terms of that it's lasted forever. And I appreciate the political commentary, Ken, because we can certainly talk about that and our amazing viewpoints here. But, I don't know. I think we've been responsible for moving this culture along in EMS for quite some time. I mean, I remember the labs of, in paramedic school assisting the paramedic, and we're so metricized. You get a trauma patient and it's bright lights and cold steel. It's load and go versus stay and play. And I do think that that we have done, or at least we have more work to do with respect to getting out of that mindset and thinking like a clinician. Because to be clear, there is a time to beat feet to the hospital, as you say, right? But I think that's predicated upon what you think is going on with the patient and all the other stuff around you. But I don't know, I would say I've seen that in EMS and even emergency medicine for quite some time. Not to mention the fact that, we're so over metricized. Your 10 minutes for trauma scene time, your 10 minutes for a 12 lead EKG, your turnaround time, your call transit time. And so I think it's something that we have to extricate, we have to extricate ourselves out of that to think as a clinician. Because I can tell you, I don't know how many times I'm on the scene of a blunt trauma, when I have the privilege of riding out with my jurisdiction and the clock's ticking and people are like, we got to go. And I think we have to kind of figure out when we can take that pause.
This topic, the sudden ambulance death syndrome, the do we stay and play, load and go, has been batted around in EMS lately a lot. Right. And a lot in social media as well. And it's such a nuanced topic. There's no right answer. The closest right answer is the patient dictates what we do. And the situation dictates what we do. You can't tell me that every asthmatic, you're going to sit on scene and go through the protocol and treat fully before you start driving to the hospital. Some of them, you're going to get that doing maybe that epi on board, you're going to throw them in. And because, hey, you're a jurisdiction that you're 45 minutes close to your closest facility, it's better that you start going now, cut down that distance, and treat on the way. But if now you are in Dr. Launer's jurisdiction and you are right around the corner, hey, maybe we do have a little bit of time to treat. Let's get the major things done and then start things that are going to happen during transport and continue through care in the hospital. I don't think I've heard the phrase yet uttered tonight, but treat through the doors. That's something that is really big in my jurisdiction from my medical director is like, hey, these patients are not going to instantaneously, just because they walk through the doors of the ER, get treatment that we think, oh well, we're not gonna do that here because the hospital's gonna do it. No, that doc's still the almighty registration has to happen first. You cannot forget about the registration aspect. But
yeah, that's the biggest
treat,
blockade to be around the corner. Yeah,
and treat through the door. That's a mantra that I tell new medics all the time, and it doesn't apply just to one type of call. It applies to everybody.
I think it would help start with a case because you're exactly right. As we said, transport is a treatment. I think I was struck by in trying to prepare for this podcast because of the extensive research that goes on before talking to all of you. I want to make sure that we're getting ourselves all prepared. I did a Google search and there was like nothing. There's only like 3 articles, and so just to define what we're talking about, it's the phenomenon. It's not that the ambulance is killing people. It's a phenomenon that what happens with sudden movement. You have a very sick patient, and some people have tried to quantify it: hypoxia, hypotension, tachycardia, unstable vital signs, altered mental status. And the mindset is transport and move first. And then when you take a patient like that and you don't either, as you said, Josh, treat through the doors, or you're not prepared to treat and the patient deteriorates, we have the thing, I don't know what happened, the patient coded. And then you take a look back at these patients, and typically there was some red flag or some alarm bell. You think of the patient that's having their GI bleed that's on the toilet and they're on the 3rd floor and you're like, we got to get them to our office where we can work. That may absolutely be the case. But if the inclination is let's just throw the person on, let's say, a MANSAC, not support the airway, we're not going to be prepared for complications. And so the sudden ambulance death syndrome is this term that happens when we are not prepared. In other words, the patients present to extremes of physiology, and we're not prepared to necessarily do all the things we need to do, whether you're BLS or ALS. And I think a couple of cases would really help kind of illustrate this phenomenon. And to be clear, before those of you start Googling and looking at PubMed, this is what's called kind of a lot of extrapolation. I mean, when you look at the patients that go into cardiac arrest, the patients in hemodynamic compromise, these are patients that tend to, they give you the red flags and then they die en route. But if we're honest with ourselves, in most cases, there's something that heralds that demise, the bradycardia, the rapidly losing loss of consciousness. And we're just talking about taking that healthy pause to say, okay, how can I get in front of this and be more prepared when the deterioration occurs?
Yeah, I think there's going back to what you guys were saying with treat to the door, I think there's a little bit of a fallacy out there too, where there's this idea where we don't need to do anything because we're right by the hospital. Like I've seen this before, and like my wife's an ER nurse at a local community hospital. She sees this all the time. Well, we were only 5 minutes away, so we just rushed the patient to you. And this train wreck will come in, and the paramedics haven't done anything, and the person's trying to die, and it's like,
Yeah. And, I think it's tough because, like you said, there's a lot of time that is, time is of the essence in a lot of these cases. And there's no question that we are against the clock in a variety of things. One of the things that started this off for me was a review that I participated in an unnamed jurisdiction. And it was a BLS crew. Hey, what's up, Moose's cat? It was a BLS crew that was encountering somebody with a STEMI. And so they were right around the corner from a hospital. And the decision was, this person's having a clear-cut STEMI, should we go? Now, we all know that depending upon your system, there are lots of options, right? Option number one is let's wait for an ALS upgrade. And we all, I think we can all agree that waiting for an ALS upgrade when they're in the shadow of a cardiac cath center, which is definitive care, is probably not the best move, right? The other option is, well, let's just start moving because, this patient's really sick, which is another option as well. So in this case, what had happened is they decided to go, which was the right thing. The patient was having a STEMI. This was an anterior STEMI. So of course the patient had the stubborn personality to go into VFib arrest. Now this happened when the doors were closed. They were already moving. The other crew that was in the back was not familiar with the ambulance layout. So now in addition to the patient going into VFib, you have to figure out while you're going to the hospital how to get the pads on the patient. How do you manage the airway? How do you notify the hospital? And so at the end of the call, the defibrillation was not delivered. The patient did fine, but they weren't able to manage the airway, and it was a very stressful call and all involved because the crew did the right thing. The BLS crew identified the abnormality. The BLS crew identified the appropriate destination. But the question is, in that quest to go to definitive care, how do we treat through the doors and how do we prepare? And so even at the BLS level, there's a lot of things we can do to kind of figure out how to get in front of that anticipated complication, right? And so I think this understanding of how to prevent and stave off sudden ambulance death syndrome really depends upon what's wrong with the patient and what your capabilities are. And it's all about taking that healthy pause and being prepared.
Yeah, and to kind of back up what you were just saying, Doc, with that specific case, in those cases where you do have someone arrest while transporting, the best option, and this is going to probably ruffle a little bit of feathers because I know it ruffled some feathers here. Stop and work the arrest in the back of the unit. At least work the arrest until the general science says the third epi. Then move. It's about 15 minutes is what they're saying. But stop, request ALS, request additional manpower, whatever it is, and you work that arrest there, because we have found over time that compressions while moving, attempting to interpret rhythms while moving, airways, medication administration, IOs, IVs, everything is so much more complicated once we're moving, and things get missed. We don't do good compressions. We don't deliver defibrillations. The basics get missed.
Not to mention, it's not safe.
Yeah, I mean,
it's just not safe at all for anybody.
I know, Moose, you came in at the tail end of this happening. I know Ken and I definitely came up in, and Dr. Leonard was there at the beginning and through it and at the end of holding onto the rail and compressing with one hand.
Yeah, and that's
and we know how ineffective that was, even when we were doing it, and we didn't even know the science. But this is like this just goes into this whole sudden ambulance death syndrome, that we need to establish our office of care, our floor of care is what they like to say here. No matter if it's a code, if it's a septic patient, if it's a hypotensive, bradycardic, tachycardic, whatever it is, we got to figure out what we can treat there that's going to keep this patient alive during movement to the unit, and then finish off that care to keep them stabilized or attempt to stabilize between you and the hospital. And I know we're going to say it a couple times, so I want to say it now. This line of definitive care. It's what a lot of people like to fall back on, is why were we going to the hospital so fast? Because the hospital is definitive care. It is a level of definitive care. We do provide some definitive care in the field. There are things that we can do that are going to stabilize that patient enough that the hospital then can escalate what we've been doing. If you look at a lot of the people that we bring into the ER, the treatments they're getting in the ER are on par or similar to what we're doing in the field. And I'm going to speak specifically to Maryland because that's what we know best. There's a lot that we do in the field that is going to be the immediate care in the ER. So why don't we start it now?
Hey, real quick, I'm hearing a lot of echoes, so if you guys aren't talking, just go on mute if you don't mind. Sorry, Dr. Lerner, I cut you off.
No, I think you make a great point, and this is where it's really hard. So I try to look at this discussion, and I just want to piggyback on what Josh said. I look at this discussion within the lens of reality, and I think it is hard. So I can hear the ECMO ECPR specialist in the background going, but wait a minute, and that's a level of definitive care that we're not in France or England or the Netherlands. And I understand that sometimes definitive care and escalation, as you so well put it, is an excellent thing to consider. And in this case, we had talked a lot about that. And I said, well, what definitive care things do you need to do in the setting of cardiac arrest? And time and again, it's compressions and defibrillation, right? And that's something it may be, I understand the hesitancy about, staying on scene, but I will agree with you 100% that we need to stop what we're doing. And until you have that Lucas device, if you have that available, applied, or until you have some type of airway control, then we can make the argument, well, if he's 5 minutes away from the hospital and this guy is, let's say, an ECMO candidate. So even in this case, I would agree with you. But, to sacrifice some of the best definitive care therapy for cardiac arrest for the sake of expediency is where, I have trouble. In other words, if you can't deliver safe, effective, minimally interrupted compressions and you don't have some type of an airway, then we're not doing our job. Because even if you're going to play that ECMO ECPR card, we still have to pay attention to those mortality-based interventions in cardiac arrest. So again, it's thinking clinically, and how do we, I think part of this sudden ambulance death syndrome treatment that we often don't talk about is communication and crew resource management in the setting of these really high acuity, low frequency scenarios. But I think this case illustrates a lot of the complexity, right? And it illustrates how we can still do everything right and things may not go well. But how do we, within the level of our capability and training, address those issues? And I would agree with you that the ambulance probably should take that healthy pause until you can secure the Lucas, recruit additional personnel, have some type of airway control, and deliver those interventions, which are very important to that patient. Agreed.
Dr. Launer, do you know, not for any one specific jurisdiction, but in general, since these protocols and understandings of on-scene resuscitation have come out, how cardiac arrest save rates have changed over the past maybe 5 to 10 years?
So this is a great question, because I think we run up against the limits of physiology, right? We all know that no matter what we do, there are positive predictors of survival from cardiac arrest. However, if you look at those jurisdictions which have protocols that incentivize this type of care, whether it's early defibrillation, whether it is minimally interrupted compressions, and sort of orchestrating that initial 10 minutes, not only does ROS increase, but I think our survival from discharge. I will say there's probably a ceiling effect here, because even in some of the best jurisdictions, survival from VFib cardiac arrest, survival neurologically intact to discharge is still like 50% max, right? So we're still kind of pushing those limits. But there's no question in my mind, and it's well supported by research, that these jurisdictions that, and cardiac arrest is a great case for this, the jurisdictions that actually pay attention and incentivize their clinicians to do some of those things with definitive care will experience improvement in those two metrics. And let's just be very clear, right? All these ECMO survival characteristics and survival statistics would not be possible if we were not delivering viable patients, right, to the hospital. So these ECMO survival rates are predicated upon good BLS. So that is an excellent question, which is beyond the scope of our podcast, but I think it's because EMS identifies survivals or identifies the factors associated with survival and then acts accordingly. So I think the proof is obviously in the concept, but yeah, truly great question, which certainly echoes the importance of coordinated systems.
And if you want a refresher on ECMO and ECPR, go listen to our episode with Dr. Kim Boswell on ECMO and ECPR. It was a great episode.
What a plug! What a great segue.
Oh yeah, I can't help but think when all of you guys have been talking about this, what we're doing essentially is a risk benefit analysis, right? And as we secure an airway and have good compressions with a Lucas device, we're now within the scope of the patient's hopefully positive outcome. We're reducing that risk of losing perfusion. Yeah. And when we're calculating the transport time to a ECMO capable facility and all these things, we're now hopefully having some benefit to that, right? And when we say extrapolate that to, say, you change your transport time to 45 minutes, suddenly the risk is not worth, the very low benefit, because we know, like you said, we are limited by physiology. So, I can't help but think in that sort of framework of a risk versus benefit.
Moose, that is, ECMO is a great case. So we've talked about the STEMI case. The ECMO case also, I think, deserves a lot of consideration, because this is a great scenario where sometimes we get mixed messages, right? We talk about let's resuscitate and stay on scene, but then, as you well pointed out, the patients that are off pump greater than 55 minutes have a much lower survival rate. So how do we reconcile that? And I tell my EMS officers, my clinicians, I say, well, look, cardiac arrest is a very time-sensitive entity, right? And if somebody is going to go on pump, and this is basically a very selective population, right? In most cases, it's the witnessed arrest, the VFib, the refractory VFib. They have very favorable characteristics. And I think that before the ambulance leaves, we need to make sure that we do our job, because we can't deliver somebody who is non-viable. But the corollary of that, right? If we don't pay attention to maintaining CO2 and maintaining compressions, it doesn't matter what ECMO center that we're sending to, the patients have a neurologically bad outcome. But the ECMO scenario that you describe is very complex, because it illustrates the extremes. I mean, yes, you've got to stay in play, but you're staying and playing until you check those boxes of the things that are actually proven to kind of link to survival. You got to get a definitive or a semi-definitive airway. You've got to get minimally interrupted compressions and high quality compressions en route. And you just can't do that if you were to take every ECMO candidate that was eligible, shove them in the back of the ambulance just to meet a time deadline. So that initial resuscitation is exceedingly important, even in the most complex cardiac arrest case scenario that you described for eCPR.
I think where the rubber really hits the road with this is also kids, right? I mean, the perfect hyperbolic example of why we should be treating versus not just the traditional scoop. And to be clear, when I started as a paramedic, there were cases where people would just scoop these kids, not do anything, and try to do everything en route, and then that kid was not viable by the time we got to the hospital, or by the time the team got to the hospital. We have to. How should I say this? I remember I had a case where I had a student that had just become a paramedic who wanted to kind of just rerun. This was, and what I told him was this. I said, listen, proximity to the hospital is not an excuse to not do your job. And it was kind of a douche saying at the time, but like it's fitting here. Like we have a certain amount of things we have to do, or the patient doesn't make it through the doors, right? You can't do care through the doors if the patient's dead when you're going through the doors. So I just wanted to say, that because just like we said, these ECMO patients, cardiac arrest patients, the pediatric patients are also an example of where historically we used to just run with them, the sicker they got, and that's now something we absolutely do not do.
That's another great, I think, case scenario which illustrates a lot of our bias in these situations. And in addition to the pediatric patients, I think the trauma patients are a very hotly debated cohort of patients where you've got to think about this. And I said earlier that whenever we say, stay and play versus load and go, we've got to expand this concept a little bit. And so if you think of this concept as applied to a trauma patient, there's no question in my mind that if you're, doing the most dangerous thing ever, and which is minding your own business, and you suffer some horrific traumatic injury, penetrating trauma really needs to be at a trauma center, right? We know that surgical hemostasis is something that, time to definitive care in the setting of surgical hemostasis, absolutely a mortality beneficial kind of intervention, right? The best place to get stabbed is in an operating room, although I wouldn't recommend it. Now, how do we translate that? How do we translate that into, our current practice, into this discussion? And I can think of no better situation with what's going on in New Orleans. There was a recent study published over there which talked about how, they're very much around the corner from trauma centers. And so the argument that a lot of people have to whole blood is they say, well, regardless of whether you have whole blood, why would you give it if you're 2 to 3 minutes away from the hospital? And the recent study out of New Orleans was actually quite landmark in its significance. And it said, for every minute that you delayed the definitive administration of blood, the mortality increased by almost like 4%. Now, this is where two things can be true, right? Penetrating trauma is one of the few things where you've got to really take that pause and say, we should probably be treating through the doors and moving. But as Moose so eloquently put it, we also have a job to do. And in some cases, the care that we provide in the field is semi or quasi-definitive, and blood is one of those interventions. And so that's something where the end of the study basically said, if the time that you're investing to stay on scene, because there was an extended on scene time for the patients that were victims of trauma that received blood, if you're going to invest the additional time on scene for the purposes of performing a definitive therapy, then that was time well spent in terms of mortality and patient outcome. So again, it's this risk-benefit analysis, this clinician thinking of, what? Yes, this is a time-sensitive emergency, we got to go, but I've got to be able to administer the life-saving therapy, because blood is not instantaneous, no matter what trauma center you're at. Even if you're not registered, right? Even if you're registered as a DOE patient, you've got to get the IV access. So in all scenarios, it comes down to this very complex synthesis of what's wrong with the patient, what can I do for the patient, and how fast do I need to get there?
I can bring up the New Orleans example of the blood and staying on scene to do it, or doing the rendezvous and taking the extra time to set up everything. We talked about this once again. Plug for another episode. Talked about this with Zaf. Where he talked about marginal gains. This is marginal gains. We are doing something, taking the time for this to gain time back for the patient on the other end. Push that goal line of the golden hour back. Golden hour, we know, has kind of been disputed and chucked in the waste bin by some people. But that's where that comes into play. And for anyone in Maryland that's listening, for a much closer jurisdiction that is encountering the same thing right now, DC. DC has 3 trauma centers within the district. And I don't know their numbers. The last one I heard, they were in the 50s to 60s of patients and units administered with an above 80% survival rate. And they're right around the corner from MedStar, Washington, a major level 1 hospital. And then they've got GW, another great level 1 trauma. And I'm blanking on the third. Anyone wants to help me out, but they have 3.
Was it Hospital Center, Howard, and GW? Or no? Is
Howard,
that right?
Yeah. Howard.
Yeah.
So they've got 3 great level 1 trauma centers, and they're giving blood and being right around the corner from their trauma centers. And they're having a great turnaround in their patients. Same thing with New Orleans. Just to kind of hammer this away for anyone that's wondering, there was a study that they did where they looked at their shock index reversal, where they're administering blood, they're right around the corner. They had a average pre-blood shock index of 1.4, and post-blood administration, I want to say it was like a 0.8, 0.6 to 0.8 was the average shock index after blood. I mean, that just shows how effective this is in reversing timelines, pushing back, giving the patient more time to get definitive surgery and survive, ultimately. That's the goal, survival.
I mean, the way I think about it is we all know how quickly hypoxia can set in if you don't have an airway, right? We all know how long it takes for acidosis when you don't have blood, right? And if those are, oftentimes the initial times are seconds to minutes, and we know that in today's world, with packaging and moving and giving report and getting the patient registered, those are definitely conversations and times that are in the minutes, not in the seconds. So we should be treating, as a basic function of time, we have to be treating.
So I have this quote. I don't know where it's from exactly, but Cody sent it to me the other day. Maybe just straight up from Cody. But this kind of factors in. The protocol is not a plan. Number one problem is not having a plan. We know the protocol and we know the procedure, but planning is a problem. And that's where this all factors in. We have to plan how we're going to attack this disease, how to work with the patient, work with our crews, and determine when is best to do certain things. That's like the whole goal of this is, pushing clinical thought. We like to talk about clinician level thinking, and some more may come from that in the social and Instagram, by the way, for those listening. And you have to, this is not A, do B. This is C, A, and think about B, C, D, E, and what, now we're going to, flip up the alphabet and do E first, possibly, because that's what is most appropriate at the time. And it takes a little higher level thinking some days, but it does come. It does come in time. I think we can all agree that we all weren't there at the beginning, but I think we are there now, hopefully.
I think that and apologies for waxing poetic on my favorite topic, this peritraumatic arrest. I mean, I joked earlier that we had no evidence about this, but in all seriousness, we know who survives, right? So in 2006, I believe, there was a paper written by the people over at London Hems, actually, and they said, who are the survivors from traumatic arrest? And essentially, that you distill that paper, and to this day, it's very true, and this has been true for the past, I don't know how many years, is that the patients that experience circulatory arrest due to trauma, if it's unwitnessed, they hardly ever survive. I mean, and time and again, you've got about 4 to 6 minutes to restore circulation, and that's it, right? The patients that are in traumatic cardiac arrest, if you can't get them to a hospital where they can fix some of the things that are wrong, again, definitive surgical control, the patient's outcome is relatively just, it's highly morbid. So what that means to me, as a pre-hospital clinician, is we've got to do everything in our power to stave that off. And you mentioned shock index. So these hypotensive trauma patients, these patients that are at the extremes of physiology, again, if effective perfusion ceases, we may be able to restore some peripheral circulation, but the neurologic outcome and the functional outcomes are so poor. So this just echoes your point that if you're in a system that has the capability of administering blood in a timely manner, absolutely worth the investment, because the the other side of that, traumatic arrest, consistently, it's one of our most quote unquote dramatic and stressful calls. But I think the battle in those cases is sometimes already lost, right? It should all be about how do we increase perfusion? How do we identify those life-threatening injuries? And so I guess what we're saying is, I'm not saying, stay and play for trauma patients. I'm saying you've got to do this kind of synthesis between, how, yes, the patient needs to be at a trauma center yesterday, but if I have some potential for life-saving treatment, and we all know the injuries which are quote unquote fixable in the field, we really have to pay some attention to deliver those therapies, such as the blood and then restoration of perfusion. So an excellent point. Very difficult to operationalize because you can't write a protocol for everything, but just be mindful of those interventions which you may be able to deliver in many EMS systems that are directly linked to mortality.
Well, I wonder if we even have this issue in the first place because of, and I would never say the protocol, but because of the dichotomies that are within the protocol, right? What do I mean by that? When the natural organization of a protocol is an algorithm and you have 2 choices, right? Or 3 choices or 4 choices, then I think the provider naturally thinks in extremes, right? Because that's in the absence of clinical education, in the absence of maybe even experience, and medical directors that encourage critical thinking, right? You may not have any other choice, and I think that's why. I mean, kudos to our listeners for listening to stuff like this and other content and trying to build that critical thinking, because at least historically. You guys are absolutely right. By the way, I came in on the latter end. I remember doing compressions while holding onto the rail like once. Actually, I think it was the first time I ever did CPR. Actually, I think before I was an EMT.
Oh, stretcher surf. We had all sorts of techniques for that.
But yeah, I wonder if the way we deliver our protocols contribute to how or why we think in these dichotomous ways.
Well, Moose, I would only say that you've addressed this on a couple of other podcasts. This has to do with clinician and pre-hospital education, right? I mean, the growth of the critical clinician, the critically thinking clinician, has to be supported in this fertile soil. And I'm also mindful of the fact that we have all sorts of different levels, right? We can't expect somebody who's new out of an academy with a new, freshly minted EMT card to talk about the nuances of physiology. But I do agree that how do we incentivize this in protocols is we have to be a little bit less algorithmic because it does support that thinking. And then people grow up in an environment where it's all or nothing. But that being said, I'm also mindful of the fact that how do we guarantee a standard of care amongst the varying levels of education and preparedness and the varying levels of EMS systems? That's why your medical directors have to be informed and everything else.
Yeah, Ken, I know you got to go soon. Did you want to add anything in since you're coming up on that time frame?
No, I don't have anything pressing to add, but thank you. I think this is a great conversation, very mindful, very demure. No, I think it's very important. I did have one kind of question here. We've talked about defibrillation, we've talked about blood administration, and I just wondered, and I know it's very situational and a very broad question, but what other treatments do you think kind of fall into that category where they're going to immediately save a life and we must do them if they're indicated? Some things that kind of come up to me are epinephrine for anaphylaxis, CPAP for the crashing respiratory patient are kind of like 2 of my really big ones.
Oh, yeah. It's huge.
Yeah. I don't know. I mean, there's so many other things that could fall into that. Obviously the bad asthmatic or COPD or those cats are going to need albuterol, that beta-2 agonist inhaled. You could probably make an argument for a lot of things. You could get as simple as aspirin for the MI patient, right? Like there's an argument to be made there. Most treatments that we have for a reason, and that reason is they're time sensitive. Right? Mm-hmm. So if somebody needs to be cardioverted, they need to be cardioverted now. If they need to be paced, they need to be paced now. Like they don't give us drugs because they're nice to have for the most part. Some, you could make an argument like, the antiemetic or something like that is nice to have. But I would say probably of what we carry, there's a really good reason for it. And if it's indicated, we should probably be doing it sooner rather than later.
So Ken, that's a great example of how we synthesize protocol. Like this is great. I wouldn't have even thought of that, but if you could link, your possible intervention, you think of a couple of interventions that are mortality based or have good patient outcome data, then that's something you could run through even at the most basic of level. So great point. So when you get, and it's not only about the procedure, it's how to prepare. So for example, if we go back to the STEMI, yes, time sensitive, let's beat feet to the hospital, but putting pads in place, making sure your suction's ready. Epinephrine, CPAP, certainly, albuterol. I would even argue things like steroids. Steroids are not an immediate issue, right, for asthma, but we know, as you mentioned, it takes some time for patients to get registered at the hospital, for them to be processed, for people to write the order. And that is a great example of how EMS can leverage class 1 therapies, beta agonists and steroids, for patients that are the sickest of the sick, because the earlier you get that therapy in, the better they do. So I just wanted to commend you and your insight for talking about the what therapies we can look at to kind of guide our actions in these critical patient encounters.
Well, Ken, I have a question for you real quick. I know you got to go. I think, what would your thought? I feel like we can split this further into things that you absolutely have to do before you move the patient, right? And then things that like you like kind of got to do before you leave, right? Because when I think about it, and the Dr. Lerner might get a little bit of a like tick here, for the true tension pneumothorax.
Oh no!
Right? Are you gonna, I would argue that you have to dart them, or what Dr. Lerner would do, before movement, because they are gonna die, right? Now, I would argue that also that a lot of times we may not recognize that, or a lot of times we think we have it when we don't, and that's another conversation. But things like that, I think that's where the epi comes in, right? For the severe allergic reaction or severe asthma attack. I truly believe that CPAP is in that. And I know that's a little bit controversial, but I really think CPAP's there because, well, no, but I think between us it's not, because we're very, what word did you, I've heard that on Instagram, demure. I don't know what that's from. I don't know what any of that is, but I've heard it.
It's a more sophisticated podcast.
Yeah, my wife sent me a thing and I was like, what does this mean? I don't understand what this means. But either way, some would say, Josh, how should I say this nicely? Never mind. People that are not on this podcast would say, oh, just slap high flow oxygen on them and take them to the ambulance, right? Like, we all know people that have done that. And I disagree. I'm like, no, we got a CPAP at the bed, right? Or at the couch or wherever the hell they are. And then move them on the CPAP. Like, whether we, stair chair them out, put them on stretcher, or whatever. So, Ken, I guess I know you got to go. I'm sorry. But back to your question, what are your thoughts on some of those things that have to happen before you even move the patient from X?
Yeah, so, it's about identifying critical life threats, right? So if you could die from this before I can get you to my ambulance, it needs to be addressed now. And decompression is a great example that you brought up. Electrical therapies that need to be done. That's why the monitor should come with you to the patient, right? Because we need to identify those
Every
things.
patient.
Yep. There's probably, there's obviously a finite list because there's a finite number of things we can do. But I think of the things we can do, if it's going to correct a problem with the airway, with the breathing, with the circulation, we need to address those things before we move the patient. Those are all critical life safety threats, right?
Does calcium for hyper K fall into that?
I would say
for
probably
true hyper
not.
K. Okay.
Okay, so if they have a sine wave and they're unresponsive and they're like circling the drain, maybe it does. That patient probably isn't going to do well if you pick them up and carry them down the stairs,
especially if you're not going to get captured with the pacer, right?
Right. But that goes back to, do we have a problem with the life threats? And I would say in that case we do, and we have something we can do to reverse it. So, you gotta address these things.
We got to put two more things on your radar for this podcast. So one is, the sudden ambulance death syndrome is a self-fulfilling prophecy, because you're absolutely right. If you don't if you don't bring the stuff to save a life to the scene of the patient, then the stuff's going to happen. And I understand, right? So there is the need to get to the hospital or to get to the ambulance, to get to your office. That's where all the things are. And no question, we've all been there. It is a pain in the ass to bring all of your stuff and all of the accoutrements, right, to somebody that's dying. The problem is dispatch may not have all the information. The patient may not have nuanced understanding of their condition. So you're absolutely right. If you do not bring the stuff that you need, whether that's suction, the monitor, the drug bag, we're not going to be able to do with all the life threats. And the final case scenario you mentioned with airways, what a great discussion about, where and when you control an airway. I think there's a lot of good discussion to be had. You talked about things like, doing a cricothyroidotomy or RSI, but you've got to be able to prepare. You've got to be able to be prepared for those things and have all the supplies necessary. So that's another great discussion about, how and where you mitigate the life threats.
Yeah, and I've touched on this a couple of times. And Doc, thanks for opening the door on airway. And this is something that has recently come up due to some events. It's not always a stepped process. Sometimes you gotta go big, and sometimes you skip everything and go to the last thing on the list, which, when it comes to airway, is a cric. And sometimes it's not taught like that. Sometimes it's, oh well, you failed a basic airway, and the ET tube failed, and the King or iGel failed, and now our final thing is a surgical cric. There's a reason that, at least in the state of Maryland, this is a non-consult procedure. Yeah. It's because when it needs to happen, it needs to happen. It's not well, I can kind of dilly-dally. If you can dilly-dally with it, they might not need it. But if they need it, they need it. And the number one indication for a cric, I want everyone to remember this, and everyone learn this, is the inability to ventilate the patient. If you cannot ventilate the patient and the only option is the cric, then pull the trigger. We all think it's like the last thing on the list. And this is coming from an instructor who, myself, who at times have thought it's the last thing on the list. But in reality, nothing's the last thing on the list. Nothing's the first thing on the list. It is all dependent on the patient. What was that, Doctor? You cut out.
There we go. You mentioned the this issue of the airway, which is fascinating. I know former Captain Sander can relate to this. The house fire situation, retrieving victims from house fires is always so dramatic, and it's fraught with peril and danger and hazards to patients and civilians alike. But I'm mindful of the fact that when that happens, firefighters are trained to rapidly extricate, and nobody would argue that we're not going to do a resuscitation inside a burning building, right? We've got to evacuate and remove the immediate life threat. But the house fire is a great example where there's so much forward momentum. You've got people running around on scene. You've got this rapid extrication of critically ill patients, and then you put them into an ambulance. And especially if they're burned or if they're children, the desire is to get to that hospital. But that's another great scenario where if you don't control the airway, if you don't take the time to get off the protective gear, if it's a firefighter, or you don't have time to position yourself to do the resuscitation, we've already sealed the outcome. So I think every situation that we've talked about here, whether it's the retrieval from a house fire, whether it's the threatened airway, whether it's that respiratory distress patient that's fatigued, who you're like, you know what, let's just slap the non-rebreather on and see if they can tolerate the 3 flights down. It really depends. In order to prevent this sudden demise after these patients are giving you signals, we have to not only bring the appropriate personnel, bring the appropriate crew, and bring the appropriate equipment to the scene of this emergency to kind of stave off that bad outcome. So just another good example I was thinking about, because you have this kind of transport momentum in a lot of cases where, whether it's the kid being brought out or the patient being rapidly extricated from a fire, the thought is we've got to go. But in those cases, it's really helpful to think about, what does this patient need? And again, in the setting of cardiac arrest, if there's no minimally interrupted compressions, defibrillation, or some type of an airway, the neurological outcome is already sealed.
So let me ask you guys this, because every single call we've talked about, every single case study we've talked about, we've been very patient-centric, which is good. But there's another variable in there, and that's the excitement and the mindset of the clinician. And I know, Josh, this kind of talks to kind of what you and Cody talked about, I think, on one of the episodes. But how do you guys manage your own emotion, your own excitement, your own inertia, like Dr. Launer said, so that you are able to, what is it, like the OODA loop, right? You're able to calm yourself down, take a look at the stimulus that's coming in, and make a good clinical decision.
Yeah, so this will be my last answer, then I really do have to go. For me, it's always a practice of grounding myself and being mindful of my surroundings. I usually start by recognizing the fact that I'm in a very high stress situation. Several come to mind as we talk about all this. Take a look around at the whole scene, at everything going on, noticing the people doing whatever they're doing, noticing how my patient looks, noticing how the bystanders are acting, noticing where I am, just being mindful and aware of everything going on. Grounding myself in the moment. Okay, I'm here. I'm aware of who I am, what my role is, what my responsibility is, and then really just looking at what my job is and that I'm the one who needs to do this, because if I don't do this right, nobody else will. That's always been my attitude. There is no 912. There is no, especially after I made EMS officer in my previous job, there was no one coming to bail me out. Like, I was the guy people called when shit was hitting the fan and they needed help, right? So I took that mentality very seriously. And I just tried to focus. And so there were times when inside I was freaking the F out, right? Like, I was like, oh my God, this can't be happening. But it was, and I was the guy there who had to fix it. So I don't know. I just kind of processed it like that. So I'll leave you guys with that, and I look forward to seeing you at the next recording. Dr. Lawner, it's always a pleasure.
Always, my
Josh,
friend.
Mustafa, have a wonderful night, everybody. Good night, America. Good night, world.
See you, Ken.
The
Thanks
show
for joining, buddy.
continues, but I have to go.
I mean, I don't know how you follow that up, but
So this will be my last thing too, because I'd like to go get some dinner before possibility the citizens call. But I feel like I do something like I kind of do what Ken does, but maybe not in such a philosophical way as he does. He definitely has a very stepped process in his mind, but I'm able to. There's a switch. I'll just say people love to call it a switch that you just kind of flip, and I can pull myself out emotionally for the time being and set it aside and know that, like, hey, there is a process of things I need to do. What and where in this process does this patient fit, and what needs to go on? And either in my mind or with my fellow providers, I start talking out loud about what's going on. This is what we have. This is what's in front of us. And it's just like checking the boxes of things. Not saying that, you're checking the box of the protocol step by step. You're just checking the box of, like, what have we done? What do we recognize for this patient?
Mm-hmm.
What needs to be done? And how are the things that we're doing right now working? And it's just, and I'll do that constantly through the call. And then, at the beginning, okay, this is what we got. We're going to do this. What do you guys think? You think that's a good idea? A better idea? As interventions are done. So I like to say, with the trauma patient, once everything's packaged up, the interventions are placed. We've got everything attached to the monitor. We're on our way to the hospital. Okay, we've done this. What else do we need to do? Have we done everything? Is there something we need to check? We need to redo, whatever it is. And it just kind of like centers me, and it's worked really well for me over the years. And I'm not saying I don't get excited on calls. There are definitely calls that amp up the heart rate. Giving blood for the first time earlier today, that definitely amped up the heart rate a little bit. I was excited for that, but it still had to. Hey, this is what we're gonna do. This is how we're gonna do it. We're gonna step our way through it, and we're gonna do this, and then we're gonna go to the hospital. And it worked out great. Everything, we had a little hiccup, and we had to work through it, and we worked through it. But just kind of bringing it down to a manageable level internally. I know that's probably so ambiguous to some people. It is a learned thing. I'll say that. It is most definitely a learned habit. And I may or may not have, some other mentality things going on in my own life that keep me a little more centered. how I separate things. But I hope that was a good answer.
No, I think this is such an important thing, and I appreciate you talking about that, because these protocols live within the application, of human beings, right? And I think as a paramedic, it took me years when I look back to figure out how to deal with this. And we develop a lot of dysfunctional and functional coping mechanisms. I remember developing some really funny internal sort of guidance documents. Like I remember, the patient's the one with the emergency, or talking about the patient's the one with the disease. In reality, it's not just learned experience, it's also education, and you can't execute these highly critical protocols without being prepared. And what's really interesting is both of you have just echoed some very core components of crew resource management, which is very important. It's not only for your own mentality when the stakes are exceedingly high and we're stressed by a high heart rate and high acuity, but it's also how we prepare for our daily operation. And those core principles of the closed loop communication, socializing the plan with your crew, pre-briefing, debriefing, speaking out loud, and taking that healthy pause. And the first thing that Ken said is acknowledging the emergency, like, guys, this really sucks. We're in a lot of trouble. This is what we have. Are really, it sets the groundwork so that we can try to make our decisions. And that's a great topic perhaps for another podcast. But I wanted to say is that, it's not just about reading, sudden ambulance death syndrome and all of a sudden being able to apply the full spectrum of protocols in medicine to patients in distress. I think there is something absolutely to be said for figuring out how to function in that space. And crew resource management is a very generic term for that exact type of communication. And it really encourages, these life-saving crews to function together as a unit and integrate things such as these contingencies, deviations from the plan, and patients who present very rudely at the extremes of physiology. But I couldn't agree more.
Yeah, when I first, I'm going to mute you, Dr. Lohner, because I'm hearing a bit of an echo.
I'm going to hop off, guys.
All right, Josh. Hey, thanks so much, man.
And not to cut you off and not hear your side of things.
No, you're fine. You're fine. Go get something to eat.
But great episode. Thanks for coming on, Doc. And after hearing everything we talked about, I think we're going to definitely have some more medical director corner.
Oh, yeah, absolutely.
Sure. So, see you guys.
See you, buddy. Yeah, I used to struggle with this. And then I had I think probably the only time I had a trauma alert that was also a STEMI, and I just freaked out like a ton. And it was legit. I mean, this lady had fallen and like crushed her skull, fell on her skull, older lady but she was also super nauseous, blah blah. And I was, let me. I just thought she was nauseous because of the head injury. I do a 12 lead, and she's having the big one, and I'm like, oh, that's probably why she fell. And I was consulting, I was excited, blah blah, and I did a terrible job at the consult. I did a terrible job at the handoff, and the doc. I don't know who this doc is. It was at the Johns Hopkins Baby Medical Center. I don't even know if that person still works there. This was years ago. This was probably when I first became a CRT, a cardiac rescue technician, not even when I was a paramedic. So this doc sent me aside, and she's like, listen, you know what you're doing, but if you don't sound like you know what you're doing, nobody has any faith in you, and you have to deliver the story for the patient. So that's where I kind of started my journey of trying to figure out how I could reach, and that's where I learned about the OODA loop, and I forget what else. There's a book. So the OODA loop, if folks don't know, is based off of a pilot, and it's like a. I don't really. We don't need to talk about the actual OODA loop steps because I don't really even follow those steps. What I do, similar to what Ken was saying, is first I just stop all stimulus from coming in, right, which is hard to do, and stop all information from coming in, and I just try to acknowledge, okay, I'm here. This sucks, and I try. Then after I acknowledge it, I try to allow information in a controlled fashion. And luckily in medicine, we know what the priority of information is. We have a primary assessment. So if I'm really stuck, and I tell my students this too, if you're ever stuck, just go back to the primary assessment. Are they alert? What's their mental status? Or do they have an airway? Are they breathing? Are they? Do they have? How's their circulation? And I will also argue, this is completely anecdotal, a lot of times when my patients were crashing, I couldn't figure out why. I missed something. As a clinician, I missed something, or something developed that I missed. And once I was able to fix that, things got better. I'm not saying that happens all the time. Sometimes our patients just crump out on us, right? But the times that I've been able to fix that is when I was able to, stop the stimulus, allow controlled stimulus in the way of a primary assessment, and then treat the things that I find. Let me ask you this, Dr. Lerner, how do you're obviously not working full-time as a physician anymore, right? Like you have like other duties. So or are you at the bedside as much as you used to be? I think you're on mute.
Nope, not full time.
Yeah.
Yeah.
So I'm in the same boat, obviously, as a paramedic. And do you feel that, let me say it this way. I felt that when I was in the field full time, I kind of built up this callus of I wouldn't get excited about things because like you just have that constant stimulation all the time. So then I was better about managing, these critical situations and getting to it. But since I got into an administrative role, it was a lot harder to build that callus up. Now I think I've gotten a lot better with it because now I'm quite frankly, I'm riding a lot more than I used to. But do you feel that do you feel the same way? I guess I should ask in your practice.
That's a great question, but I mean, I probably send more emails than I ever did in my life. I mean, my administrative time goes way up, but I'm very fortunate that my administrative time is dedicated to critical care transport and operational EMS. And so I feel like this comes up a lot. And so in my clinical shifts and when I ride out, either in the ground or in the air or with the crews, I think it actually has become more important. And I think that it's not about callous, but you become more detached. I think after you have been in that role and now you're tasked with sort of deconstructing some of these challenges and you're tasked with doing a lot of the oversight, I think it reinforces this practice of developing that healthy distance because you have the perspective of quality assurance. So I am not trying to say that I am more or less prepared, but I actually think in some ways it helps me have that healthy detachment because you've seen so much and you train so much and you debrief the crews so much that it just reiterates the importance of this. Now, absolutely, I am not saying that I don't get excited during an intubation or trying to watch an intern, fumble his or her first way through an intubation. Hopefully they're not fumbling. And there are a lot of things that are stressful. But I think the conditioning and the learning of that behavior till it's second nature. And Mike Loria, credit to him, he gives a great lecture on this. He talks about the conditioning and compares certainly, special forces operators to a lot of people in EMS. I think it's as Josh said, it's a learned behavior. So I'm very fortunate now that I'm still clinically active enough that I haven't in my mind seen the degradation of, what I feel to be a clinical functionality. But I think in my perspective as a medical director, the constant training, the constant education, the constant quality assurance and oversight really helps me reinforce these core principles. And so I hear myself in my own head, like you said, okay, this is a terrible situation. What are we going to do to get out of it? And sometimes it's also the realization that no matter what you do, sometimes the patients will expire. Sometimes the patients will decompensate. But it helps on the back end because I have less of the doubts of, oh my gosh, could I have done everything possible? When I first started, it's a long answer, but I remember very clearly when I first started as an attending physician, I had a lot of experience as a paramedic, but I was up regularly because I would come home from my shifts and decompress and just go through the charts and say, oh my gosh, like I can't believe this happened, or did I do everything that I could possibly have done? And so maybe my method is it's perceived as some as too quiet. Maybe it's perceived as people that are slow, methodical, or sometimes callous. But I think it's less of being callous and more of being appropriately detached so you can execute some of these core principles and function in that high acuity kind of high stakes environment. And who knows, right? We all have our own preferences and we all have our own strategies. It's just something that has helped me, throughout the years function the same way, no matter how difficult the situation is, because again, as Ken and Josh and you put it, we have a job to do. And I take that very seriously.
Absolutely. So what else did you want to talk about while we're in your corner?
Oh, I think that's good. I'm very privileged to have a piece of this place. So I think my corner is already filled.
We're blessed to have you.
Yeah, no, yourself as well. I appreciate the opportunity and hopefully it's useful. I think this is a great perspective where we can kind of transcend some of the political and educational and protocol based issues. And it's a relevant trend. And maybe in 10 years, once we fully operationalize all these critical patient protocols won't have this problem, but it's great to have a forum where we can call attention and rely on the expertise and get some feedback from our listeners. So hopefully people will find it useful.
Yeah, I think we have an opportunity here because we transcend the general like processes and things, right? Like we record, I edit, or Josh edits, or somebody else edits, Ken edits, and then we spit it out to the world. And there's no red tape, there's nothing. We just do what we gotta do. And we couldn't do any of this without our listeners. So, did you have any closing comments? Or are you good?
Well, I just think it's an absolute privilege to be in pre-hospital medicine, and I really think that's a great way of describing it. What we do is on the cutting edge. It is not out of hospital medicine. We are a link in that chain, and so everything we do is guided by the desire to make some stuff better. And kudos to all you do on a daily basis. So stay safe, but I think that's about it.
Cool. Well, thank you so much, guys, for listening. We really appreciate all of our regular listeners. The only thing I would ask is, continue to follow us on social media and contribute. We don't know what we don't know, right? And we want to hear from the folks that are doing the work, in the field, on the road, or in the air, as Dr. Lohner's folks do as well. In terms of following, please follow us on Instagram. We are working on a few other things right now. The other thing I would really ask is if you're listening on Spotify, please follow us on Spotify. We're really trying to do some cool stuff with them. So, and share with your friends. Share with your friends and give us feedback, whatever whenever you can. But wherever you're listening, good morning, good evening, good night. Thank you very much. And that's all for now. Thanks so much.